Thank you very much for the invitation to talk today. I'm more an academic rather than really working in hospitals, but I worked with lots of colleagues in hospitals over the years. A bit of a disclaimer here, but really nothing pertinent, but I thought I had to come clean today. I've got to say, I do not have a preferred bacteria, right? This last speakers, Pseudomonas cerevisiae, indeed, I feel bad because over the last 30 years, what I've tried to endeavor is how to kill them better. So I've murdered billions of bacteria or trillions of bacteria over the years. Right, so what I'm going to talk again is about definitions first before I move towards biofilms. And again, the importance of, for me, vocabulary. Cleaning, disinfection, for me, they're very, very different. And again, we had some fantastic talk yesterday as well. And some talks about management of outbreaks, and they're thinking we're using cleaning. And for me, cleaning is the removal of dirt, right? And through cleaning, whatever you're using to clean, to remove the dirt, you're going to move bugs about. But it's not controlling your bacteria. For that, for me, is disinfections, that you kill the bacteria. And actually, talking to some colleague in the US as well, certainly management outbreaks, they use disinfectant, and now the trend with some colleagues in the US is to use some very, very powerful disinfectant as well on the surfaces. Well, still safe for surfaces, but very powerful one, especially the oxidizing agent, and then really reducing the outbreaks. So for me, it's a question of definitions. Cleaning is really removing of dirt, but for me, managing outbreaks, you're certainly, hopefully, using more a robust approach to eliminate microorganisms rather than just removing them or moving them around. On disinfections, then, as I said, they kill microorganisms. You've got different levels of disinfection, which I will talk briefly about. But also, again, it's a common thing I'm going to say today is how you use the product and what the products look like. Here you've got delivery, the applicator, how you apply a disinfectant on surfaces matters, and matters quite a lot. So last thing as well, sterilization is the absence of microorganism. It's absolutely impossible to sterilize environmental surfaces. As you all know, microorganisms are going to be found on the surfaces post-disinfections. So empirically, since late 1960s, you had a scientist called Spalding classifications looking at what level of disinfection you need to handle different type of devices, whether they're critical, semi-critical, or non-critical devices. And with critical devices, it's sterilization. So usually it's physical sterilization, heat, radiation sterilization. For some devices, high-level disinfection is acceptable, but again, those are very powerful chemistry you're going to use. For semi-critical devices, those devices that come in contact with intact mucous membranes, then again, high-level disinfection is certainly recommended, while sterilization is also possible. And then it's for the non-critical items. And there's a lot of debates, and we'll show you next slide as well, is cleaning or disinfection. So cleaning, as I said, you're removing basically organic matters and dirt, but you don't really eliminate microorganisms. While low disinfection is certainly probably recommended because I'm more a disinfection type of person, of course, I would say that. Interestingly, the last speaker mentions when they reviewed the evidence in the neonatal unit about what to do, especially about share medical items, is, again, that's a theme I'm going to mention, is you've got a product, but on its own, it's not good enough. It's how you're going to use it and how often. And a few years ago, we reviewed all the decontamination protocols of shared medical items. We've looked at, I think, 35 trusts. We looked at 1,279 decontamination protocols. And what we certainly observe is a really wide variety of practices. The big question is methods, is how the trusts were decontaminating the same type of items, and there was a very wide variety of interventions. Who was supposed to do it? Who was responsible for that? Again, wide variety of answers to that. Finally, how frequently you were doing that? Again, very wide diversity of responses between trusts to decontaminate the same items as well. So again, those things matters because you can have a very good product, but if it's not being used properly, or if we don't know who's supposed to use it, it's not going to work at all. So when we're looking at disinfections or using a product properly, you've got lots of different parameters that really matter. Compliance, very importantly, how the product is being used, product efficacy itself, on your targeted microorganisms, and that's going to be biofilm in a minute. And for each of those categories, you've got different parameters. In yellow, product efficacy, so that's the manufacturers. You've got very little handled by that, it's your formulation. The product they're trying to sell you, the evidence is going to show that the product works in a very defined way. Very often they rely on standard efficacy testing, those EN standards, kill 99.99% of bugs on surfaces, you know, those sort of things. They work. How do they work in practice? That's a different thing, right? Very often they will send you maybe a formulations, but they're not going to indicate to you how to use it, what sort of material, cloth material you're going to use if you're using a spray, for example. They're not going to tell you that. They should. And my advice to manufacturers is you need to be very precise, because depending on the material you use with your disinfectant, it's going to be matters. You know you've got lots of antimicrobial wipe. They work very well. Again, for the manufacturers is understanding the right combination between formulation and the materials. And that matters, and we'll see that in a minute. In terms of product usage, well, it's going to be surfaces, organic loads. If you've got soiling, you need to clean first, usually, and then disinfect, as you know. Contact time, big issues. Wiping, if you've got antimicrobial wipe, even if you've got the spray on wipes, your wiping movement is going to be what? 10, 15 seconds, 30 seconds as much, right? And some manufacturers will tell you, my product works within 60 minutes. Well, that's not going to happen. Delivery system, again, I mentioned very important on temperature, relative humidity, depending on what you use. Targeted pathogens, what microorganism we're going to find? What microorganism you got on the world? What numbers, you know? And also, what association? That means if you got biofilm or not. So, to give you an example, we've done a double crossover study quite a number of years ago with a purposely made a wipe product will contain a sporicidal, so it's an oxidizing agent, was very, very powerful. And we compare that with what they were doing in that hospital, in those wards, which was sodium hypochlorite in a bucket and using some type of cloth. And going back to the bucket and surface cleaning or disinfection, going back and so on and so forth. So 2 different wards, 2 different interventions over 29 weeks, a baseline intervention, so that's a purple bar. On what we were doing, we were just looking at environmental contamination, see how many bugs we've got on surfaces. So purple bar are the baseline, see what we find in the surfaces before the intervention. On the graph on the right-hand side, we started using that's a purposely made sporicidal wipes. And then, after 3 months, we swap again for cleaning using the chlorine in a bucket, right? On the graph on the left-hand side, it's way around, baseline, chlorine, and then those wipes. So what we certainly can see is after the baseline study, what we've done is education, how to use the product, very importantly. And you can see is using that purposely made a product, that wipe, then we really reduce the contamination on surfaces. When we swap over to, again, the sodium hypochlorite in bucket, number of contamination, level of contamination on surfaces going up, right? In the other ward is after the baseline study, when we educated, or when we train or educate the cleaner how to use a product, where you could see a huge reduction already on that education between the purple bar and the red bar. And then when we swap to this sporicidal wipe after 3 months, you can see a further reduction for most of the surfaces. So it's telling you that 2 things, education is very important. And secondly is if you've got a product that is purposely made to disinfect the surfaces, it might actually be better than some other type of intervention, especially sodium hypochlorite in a bucket. Still from the same study, we looked at MDRO, so same type of information here, the baseline, the first ward, Phase 1 is where we use that sporicidal wipe. You can see the MDRO really decrease quite a lot. We still find some, especially some VRE on the surfaces, but really huge decrease. When we switch back to using sodium hypochlorite in the bucket, those number of MDRO increased again. The second ward, baseline, then we use the chlorine first. That's different. Again, it's education. And then using that wipe, then you decrease those MDRO further. And again, we just add VRE there. So it works. So why, again, what you're doing in terms of disinfections, if you're using a wipe or if you're using a spray and then a material on surfaces, you're still going to use a material. And there's got lots of factors that impact the efficacy. You might not think about it because that's what you're doing, but as an academic, we're quite complex on thinking what matters, how does it work, what's going to impact the efficacy. So in those yellow bubbles are the product itself, right? So things you cannot control as an end user. In green, the type of microorganisms. In blue is compliance. And in red, those red bubbles are product usage as well. So you've got all those factors that really dictate that your product is going to be efficacious or not. So we can actually act on any of those to improve the efficacy of your product. So that led me now to the bulk of this talk about microorganisms. Different type of microorganisms got different responses towards disinfectants. Some of them are highly resistant, naturally resistant. We call that intrinsic resistance to disinfection. For example, prions, endospores are very, very tough to kill, and you will know that. I think we had a fantastic talk yesterday about C. diff. Well, C. diff disinfection is pretty tough, right? And then we've got a number of microorganisms in the middle. They're called intermediate resistant. So a number of products, you need high-level disinfection for those ones mostly. And then at the bottom part where you've got envelope viruses, like I've got to say the coronavirus, the COVID, there was really never an issue to kill it on surfaces. And you've got gram-positive usually, that anything really very susceptible to biocides. So we know that different microorganisms have got different susceptibility to different type of product. But what matters is if they form a biofilm. So the last two talks, they introduced biofilms, so I don't have to do that, which is nice. But very importantly, a brilliant paper review from Jonathan and colleagues, which I modified a little bit, is what biofilms matter. So if you use a disinfectant, or an antibiotic, the same, a disinfectant against planktonic cells, so bacteria, individual bacteria in suspension, well, they're quite susceptible, right? If you have those bacteria in a suspension, you dry them on the surface, and then you use this disinfectant, they're about 10 times less susceptible to that disinfectant, right? If they form a biofilm, right, they're about 1,000 times less susceptible to that disinfectant or that antimicrobial, right? And what I've added is I'm going to talk about dry surface biofilms. Hopefully, most of you will know what dry surface biofilms. If you don't, you will learn about it in a minute. If we've got those different types now of biofilm called dry surface biofilm, they're even less susceptible to your normal hydrated biofilms that we find in the drain that Mark on the previous speaker mentioned as well. So yes, biofilm matters, because when we've got a bacteria or fungus, again, yesterday was a fantastic speaker on fungus. If you've got a fungus or a bacteria in a biofilm, far less susceptible to your disinfectant or intervention. So in healthcare, what do you find biofilm on? What do they matter? Well, again, the previous two talks, fantastic talks about the drains. Then yes, you're going to have lots of loads of biofilm in the drain. Thank you for Mark showing that brilliant photos of all those biofilm you could see in the drains and the gangs, absolutely. But I would put to you is, in the drain biofilm, I will show you, you've got different parts of the drains. You've got part where you've got always water, so you're going to have a hydrated biofilms. And you've got part, for example, between the trap and the washer, where it's semi-dry, where you can have possibly a dry surface biofilms. Medical devices, again, you've got different type of biofilms. You can have some very heavy biofilm, you can see, especially in distal part of endoscopes, for example. But in the lumen of the endoscopes, now we know we've got dry surface biofilms, and that's some fantastic work from a colleague from Winnipeg, Michel Alpha, just demonstrated fantastic pictures of dry surface biofilm in the lumen, post-sterilization, post-high-level disinfection, I should say. And then we've got medical equipment. It's dry, you're going to have some dry surface biofilms. And again, quite an issue here. So if we start with a bit of drain, so those hydrated biofilms, how difficult they are. As I said, you've got different part of the drain. And in the lab, I had undergraduate students on a project wondering is, if you've got Pseudomonas aeruginosa, and oh, thank you very much. If you've got Pseudomonas aeruginosa, which is a favorite microorganism for Mark here, is how fast, if you've got the Pseudomonas aeruginosa in the pink bit there, how fast does it take for the Pseudomonas to crawl back to the sink, right? So we did a simple experiment in the lab on measuring how fast it was moving up, right? And the result is about 0.1 centimeters, so 10 millimeters per hour. That's how fast they're going, right? And we've got about 10,000 bugs in that bottom part, how fast they're growing. So you can imagine if you manage to decolonize or to decontaminate your sink up to down to the trap, if you've got Pseudomonas in the trap, well, they'll grow back up very, very quickly. So I put that slide here because I explain the next slide I'm going to show you, where we were interested in biofilm, especially in a drain biofilm. So we suddenly designed a model to look at the complexity of the drain biofilms. As I said, the different parts between the washer on the trap, on after the trap, on what's come after the trap. So we've designed things. We're able to do a very complex biofilms that we actually isolated from one of our drains, and look at interventions. You know, how good are the product you're using to eliminate those drain biofilms, you know? So this is some of the results. We've got more results, but I can't talk about them just yet. And you've got three colors here. The dark correspond to the front section, so between the washer and the trap. The blue one in the middle, that's the trap, which is always liquid. And the pale green one is after the trap. You know? So we're looking at different section of your sink and what grows on the intervention. And here you've got different intervention with sodium hypochlorite, NDCC, an anionic surfactant, peracetic acid at very high concentrations, and of course no treatment whatsoever. And you can see is you've got different impact, you know, different impact of those biocides. The treatment was a 3 times 15 minutes dose in the sink. And then we sample, neutralize, and see what's left. And as you can see, that actually we still got plenty of bugs there, even after those intervention, except with that very high concentration of peracetic acid. Very important to us and to you as well is if you're using a disinfectant in your sink, you're thinking, how safe is my sink? I mean, how fast those microorganisms in the trap that haven't killed, can they regrow? Can they form another biofilms? So for us, it was very important to look at what's called a regrowth test, is how fast does biofilm form after treatment, right? And as you can see, 4 days after the treatment, we sample those sink, and then you can see all those models, and then you can see the initial intervention, and you can see all the microorganisms, especially in the middle part, in the trap, growing back to very high level, right? Except, again, for the peracetic acid. Complex biofilms. Very often in the literature, people have used a monospecies biofilm that don't represent the complexity of your biofilm. When you've got a complex biofilm, it's much tougher to destroy and to control. And this is part of our biofilm we're using, so lots of different species. I'm showing you that because, again, looking at gene abundance, so what different species we have before and after interventions. And then you can see if we're using sodium hypochlorite, what regrow is an identical biofilm. So if we had any MDRO in that biofilm, they regrow as well. If we looked at a peracetic acid, For example, then you can see those at the blue bar, the biofilm you grow is completely different in that experiment we've done, all right? And that's what is a good news for us, because you're thinking, well, if I had any MDRO, anything like that, they're probably gone, right? But if we're using sodium hypochlorite on ADDCC, I regrow in identical biofilms, right? So we've done a far more experiment than that. I can't talk to you about that because I haven't been published, but where we're looking, and I think it's Mark mentions genes as well, resistance genes as well. So you've got the bacteria, you've got the MDRO, having lots of resistant genes, especially in plasmid. We looked at the impact of disinfectant on controlling those resistant genes because that's a new sort of a way to look at controlling AMR. On the bottom line is most of the disinfectant we are using do not control those genes, but that's for another talk, another day. So, hydrated biofilms, your drained biofilms, very difficult to control. Moving on now to the drain surface biofilm. Those are new type of biofilm. If you don't know what a dry surface biofilm, they are very widespread. Okay, that science of dry surface biofilm is only 10 years old, so it's very, very new. But when we sample surfaces in hospitals, we can find the dry surface biofilms on 90 to 95% of the samples we surface. So they look like a biofilm, but they're very thin, right? I mean, Mark showed you a fantastic picture of the drains. You can visibly see those biofilms. A dry surface biofilm, you cannot see it. It's about 30 to 50 microns on the surfaces. Very hard to see. More problematic as well, they are usually not touched by disinfections. And I'll tell you why in a second. More important as well is if using swabbing for environmental monitoring, and I think our previous colleague mentioned the efficacy of environmental monitoring, you will not detect a dry surface biofilm with just wet swabbing, right? So when it's dry on the surface, it might not do anything. It might not be transferable, right? So we're saying, well, it doesn't really matter if we've got dry surface biofilms, right? But I will show you otherwise. But remember, we cannot detect them by normal swabbing. So composition of a dry surface biofilm, very complex, mostly gram-positive bacteria, lots of stuff, imagine lots of bacilli species as well. But embedded in those dry surface biofilms, you've got also sometimes some gram-negative. We had some Acinetobacter as well. I think we've seen some CP as well, we've isolated as well, and so on. So we've got them as well, but mostly, as you imagine, are bacteria that survive desiccation, so mostly your gram-positive bacteria. So, as I said, do they matter? I mean, when they're dry on surfaces, if they're not disturbed, they're not transferable. You're thinking, well, I don't really care, you know, they're there, they do nothing, right? Well, wrong. When they're being disturbed with interventions, after cleaning or disinfectant, when you disturb them, and especially mechanically disturb them, they're becoming highly transferable. So what that table shows is we've got samples from the hospitals. First, we check we've got no bacteria with swabbing. Negative, so I said we've got nothing there. Then we check that we've got a dry surface biofilms. Yes, we do. And then we do an intervention. We wipe, so very abrasive wiping with either water or sodium hypochlorite at, I can't remember what was the concentrated sodium hypochlorite, but 1000 ppm. And then we look at transfer. What's left on the surfaces, is it transferable? And you can see that in red, most of the cases after that intervention, so it's really wiping, so it's just not swabbing, it's really mechanical wiping, then it's highly transferable. So you've got those bacteria still surviving even after sodium hypochlorite. They are fairly viable and highly transferable. So does it matter to have a dry surface biofilm on surface? Well, I would say, well, yes, it kind of does. So for us, when we look at dry surface biofilms, knowing the dry surface biofilm, again, what matters? When you look at recommendations about, again, disinfection interventions, the purpose of disinfectant, when you look at all the trust documentation, is to render the surface safe. I don't know what that means, you know? What does that mean? I don't know. When we look at dry surface biofilms, I'm thinking, well, we need to look at two things. I know they can be highly transferable after intervention. So what I'm going to look at is both the reduction in viability of bacteria in the dry surface biofilm following intervention, and then I'm going to look at the transfer, if they're transferable or not. Those are two parameters which, in my view, make the surface safe. You don't want to disturb the biofilms and then do nothing, and then suddenly the bacteria are being transmissible to other surfaces or the hands. So here what we've done is use at a number of commercial products, benzalkonium chloride, a chlorine dioxide generator in a wipe. So the commercial product, that's the ref ones, sodium hypochlorite is something we've done in the lab, and then other commercially available product, all with a wipe, right? And what we find is mechanical removal together with most of those products were necessary to really reduce your biofilm, your bacteria viability in the biofilm by at least 4 logs. So it's what's green more than 4 logs, red less than 4 logs. But it's really, again, as I said, formulation on delivery material together. We're looking at a product, right? So some products were better than others, right? When we're looking at other intervention, like VHP, in those conditions, not all VHP, just as a disclaimer, the one we've used, then it doesn't touch our dry surface biofilm in those conditions, right? So for us, mechanical removal on disinfection is absolutely essential to control those dry surface biofilm from the surface. But when we're looking at the second parameter, transferability post-intervention, then you can see now you've got really, for me, only 2 products that really work very well, because those products not only manage to reduce your viability bacteria in the biofilm quite a lot, but then what's left on surfaces is not transferable. Okay, so those products are, for me, safer. So again, I'm really pushing manufacturers on regulator to look at different parameters when we're looking at disinfection now. So finally is, do dry surface biofilm matters? As I said, they're highly transferable when doing disturb. They can contain MDRO, but very importantly for me is, do they matter on surfaces? What do they do to the bacteria? How long a bacteria in a dry surface biofilm survive on surfaces? Those are the latest results from a fantastic PhD student of mine, Ruby Arsent, on looking at VRE. VRE survival over 84 weeks, all right? We look at epidemic strains, non-epidemic strains, VRE, non-VRE. In a dry surface biofilm, they survive in a very high number, so 10 to the 6, through 84 weeks. We do not have a decrease in numbers. So what we're saying is, in the form of a dry surface biofilm, those bacteria can survive on your surface, for a very long time, in high number. And remember, they are not being, you cannot detect them with normal swabbing. So that certainly make us thought with some colleague like Brett Mitchell, and I think John in the room has done that before, really thinking about what's the danger of having those microorganisms that you cannot see. You know, can they be responsible for the outbreak you see or the contamination of naive patients that go into a room that was previously occupied by a patient with an MDR? Is that the solution? My theory is, yes, that can certainly be the dry surface biofilm. They are not detectable, very difficult to control. They're still there. So one of the reasons why you might have a transmission of MDRO in those rooms is possibly a dry surface biofilm, but again, we need more evidence for that at the end of the day. Right, finally, the biggest issue we have in terms of biofilm testing, we know a hydrated biofilm, very important to control, very important for manufacturers to sell you product that works. Well, in Europe, there's no standard efficacy tests. You know, you've got standard efficacy tests to make a product claim on label. So when they sell you a product saying it killed 99.99% of my bugs, yes, it does do that. Against biofilm, there's no standard testing in Europe just yet. All right, there's one being designed at the moment for medical devices. So in the next couple of years, hopefully, we'll have a standard in Europe for that. With the British Standard Institute next month, I'm going to start working on a standard for dry surface biofilm disinfection as well. So those are good news. Otherwise, you've got nothing. right? In the US, we've got a few standards that exist. They're very, very specific from the EPA. They're based on Pseudomonas, usually on Star Forest biofilms. They're trying to understand the importance of dry surface biofilms. So what they're doing is they're doing a wet biofilms with Pseudomonas, dry that wet biofilm as a test, as a test protocol. But a wet biofilm which is dry is not a dry surface biofilm. So lots of education, again, for me to do for those colleagues in the EPA, but also in Europe. So again, very difficult at the moment for companies to make a product claim against biofilms. Not impossible. In the UK, it needs to be agreed by the HSE. Not impossible, but certainly not there quite yet. So with that, last slide, again, a bit of a summary is, again, those standard protocols, nothing really yet pertinent in Europe, but things are coming, which is going to be very, very good for you, practitioner, because suddenly you're going to have manufacturers with a claim against biofilms, how to control your biofilm in hospital. With that, I thank you very much. I need to thank all those guys, because again, they're all doing the work. Like Mark, I do nothing. I'm just presenting. So they're all fantastic guys. Thank you very much.